Okay, so I'm going to talk about ischemia. I'm going to try to show at least our audience how bypass is both art and science as well. Disclosures, like a cogent, but two other very important disclosures. I'm a huge admirer of Rhoton, and I am a little bit addicted to math and physics. So you'll understand what I'm going to talk about. I'm going to try the outline. Physiology of ischemia, little math and physics and CFD of bypasses, surgical principles and techniques based on that math and physics, very quick surgical results and very quick work in progress. Physiology, well, this has been known for a long time. Oxygen extraction fraction that goes up in the stage 2 ischemia, the interplay between CBF, CMRO2, and OEF. Stage 1 autoregulatory vasodilation, you can see in the right graph what happens to CBV, CBF, OEF in stage 1, and it's only in stage 2 that OEF will go up, as you can see here. The cost study, I'm not going to go over it. You know, it was negative for bypass. We've published kind of a semi-rebuttal when it came out with criticisms. Absolutely no time to go over any of that. But I just want to remind you that of the Kaplan-Meier curves of the cost results, they began to cross right here. By contradistinction, the Sampras intracranial stent study, the curves never crossed, meaning surgical morbidity was the reason why cost didn't seem to work, while intracranial stenting, it was both surgical morbidity and lack of effectiveness. Nobody is arguing that bypass for ischemia cannot lead to improvement. The problem is, can you do it with low enough morbidity? Grubb himself said, had the surgical M&M been 8% instead of 15%, cost would have been a positive study in favor of surgery. Luckily, the Chinese did not listen to the cost investigators, and they have their own CMOS study going on, the results of which I'm not aware of. Okay, bypass for ischemia. Let's get you a little bit, a touch of math and physics. We're going to be thanking Pythagoras and his geometry friends for making us understand how to fashion the bypass conduits. We have to, of course, thank Bernouilli. So what is Bernouilli's equation? Very simply stated, it's pressure plus kinetic energy of flow plus potential energy. They remain constant, meaning if you have a conduit that is narrowed here, meaning velocity goes up, meaning kinetic energy goes up, the pressure must go down. And you all know this principle. It's a little more complicated than that, but that's certainly good enough for our purposes. And in a conduit like this, where there is a hydrostatic change, that also gets into the as a factor. What is Hagen-Poiseuille's law? Well, that has everything to do with viscosity and friction in the wall of the vessel, and that's the equation. And what makes the resistance higher? The longer the conduit, the more viscosity, and inversely proportional to the 4th power of R. That's the resistance that will determine the interplay between flow rate and the delta P. And of course, you can see the exquisite effect of R in this curve on the right on the relative flow. I'm going to come back at the end of the talk, a little an analogy between Poiseuille's law and Ohm's law in electricity and resistors and so forth. It's a very similar concept. This was actually Poiseuille's setup in 1846, through which he devised or discovered, I guess, the law. Flow dynamics, of course, very complicated topic, and I certainly don't claim to understand it at all, but it is based on essentially continuity equations and momentum equations, and that determines everything else. If we could understand it and predict it, we would understand how to construct the absolutely perfect bypass every time. To solve this, you have to solve 3 things. fundamental principles, conservation of mass, Newton's second law, conservation of energy. What can we as surgeons, what do we control when we make a bypass? We do not control really blood rheology or morphology of donor surface. We only control the geometry of the bypass and the donor to recipient diameter ratio. So what are causes of failure when we do a bypass? Well, surgical injury, compliance mismatch between donor and recipient. And this is the next two lines are very important. If you have too large of a donor, you will achieve low wall shear stress and intimal thickening. If you have too small of a donor, and when I say too large and too small, I mean relative to the recipient, then you will get high wall shear stress and endothelial injury. These two extremes are both bad. We need to achieve or try to achieve a relatively physiologic range of wall shear stress. Wall shear stress, let me change this a little. Wall shear stress is inversely proportional to D3, but if you don't want to think of it in mathematical terms, it's velocity of blood times viscosity divided by vessel diameter, not in those power, it's D3. When we do a bypass, we have to think of the toe, the heel, and regarding wall shear stress, you have to think of the floor at the recipient and the angle at which you construct it. So for example, 25-degree angle in this model here, this angle here, much better than 60-degree. Look at that, much less turbulence than here. Look at that in a more colored way, comparing 45-degree angles end to side with 25-degree, much less turbulence at the 25-degree. Particularly look at the toe area of the bypass and look at the floor of the recipient. So the take-home message from those couple of studies I showed you, the smaller the angle results in less turbulence, less stagnation, more physiologic wall shear stress ranges. This study looked at different angles of bypass, end to side, 25, 45, 60, and different diameters of donor, with the donor being smaller or equal or larger than the recipient. They analyzed all these very important factors. And again, I'm not going to bore you to death with the math of it, but just a visual of what it showed. Essentially, the left column is a smaller donor, the middle column is when they're equal, the right column is when it is larger, and there is a distinct, and again, without going into the second graph, the take-home message from that is laminar flow is less at the floor of the recipient when you have a smaller donor. The stagnation point, which is bad to have because that will create thrombosis, shifts proximally the wider the donor up to a limit. The OSI increases with a small angle and a larger donor, and wall shear stress, both spatially and temporally, the variation on wall shear stress is maximal at the floor and the toe. And it decreases with a smaller angle and larger donor. So the take-home message, low wall shear stress is bad, high wall shear stress is bad. The vessels will always try to adapt eventually to achieve as near physiologic wall shear stress as it can. The stagnation point shift is a good thing, and it occurs more at 25-degree of a bypass, for example, than a 45 or a 60. So the lower the angle, the higher the diameter ratio up to a point, improves wall shear stress and the other factors. And this is very interesting. This is bypasses followed over time and calculating wall shear stress. The vessel seems to want to achieve physiologic wall shear stress eventually, even though at the beginning, after you construct the bypass, it could be very high or it could be very low. That seems to be, I'm not going to call it a constant of nature, but certainly a biologic constant that our vessels love to do. Another study showing the same thing, I'll skip that. Surgical principles and techniques. Well, we all know the Rhoton rules of 3 for posterior fossa anatomy. So when I thought of this many years ago about bypasses, I realized it is a rule of 3 for bypasses, in the sense that you have to plan, execute, and verify what you have done. Planning comes in 3 categories, and each one of those categories is divided into 3s. Execution is the same. Verification of flow is the same. You can categorize bypasses into 5 types based on number of anastomoses and types of donors. Any bypass, simple or complex, we can fit it in any of these cells. They all have different names, but the principle is the same. To echo what Mustafa has said, it's very important to understand your instrumentation, your position. Going now back to physics, you need to understand that your instruments are levers, and the amount of force you put in your fingers, how it transmits to the tip of the instrument, and how different, for example, it is to suture with a forceps versus a needle holder. Just basic physics will show you all the equations you need to know. This is the difference between a class 1, so-called class 1A, and a class 3 lever. So we talked about the geometry. Well, what are the 3 geometries? End to side, thanking Pythagoras, if you fish mouth by the diameter of the vessel, of the donor, you will quadruple the cross-sectional area. That's where the power of fish mouthing is. Now, of course, it comes at the cost of doubling the length of the anastomosis. When you do end-to-end, whenever possible, you want to achieve the same principle by obliquing your cut rather than doing a 90 degree to 90 degree. And of course, side to side, you have to know how to do a running suture. All the others, or the other 2 I've shown you, you certainly can do simply interrupted, but here you must master the technique of running the back wall. And these are the usual sites for side-to-side bypass. Where do you place your arteriotomy in the side-to-side? At least bypass, the way I do it, where it's in red, meaning you don't want to do the arteriotomy on top of both vessels, even though it's the best view, but it's the worst apposition. You don't want to do it where it's the best apposition, but the worst view. I choose, I split the difference and do it in between. You can call it 130, then 30. Quick examples. I'm going to go quickly on this. Our 2 previous speakers have shown examples. This is Moyamoya, but just to show you the principles of what we're doing, it's important to measure vasomotor reactivity. We do it in Miami here at our center with transcranial Doppler, with this formula, and this woman who actually is a neurology stroke nurse, very poor VMR on both sides. This is many years ago. We did SPECT with Diamox. Now we do CT perfusion or MI perfusion. This is an example of a double barrel bypass, taking both vessels to do measuring flow. I am absolutely a believer of quantitation. You need to measure flow. This is a flow meter in cc per minute, not centimeter per second. This is cc per minute. You measure the flow of the recipient. You do your bypass. You measure the flow when you finish. And I've collected all this data for the last 20 years now. And my current fellow, Nicholas Khan, is actually helped me analyze all this as we speak. So this is the flow at the end, and you examine how does it split, antigrade, retrograde, and so forth. We did the first side, and I brought her back a few weeks later and did the other side. Then I did the angiogram. So that's your kind of poster child of bilateral Moyamoya bypasses. Atherosclerotic ischemia. More controversial, but properly selected patients absolutely benefit. This is a man who was having daily TIAs. He was 76, carotid artery occlusion. You can see that. We studied him physiologically. We established that he has misery perfusion. His VMR was 19%. In the other hemisphere, it was 55%. Did a bypass, has not had a single TIA till he died 10 years later at 86 from a heart attack. Here he was early post-op. What are my surgical results with bypasses for Moyamoya and ischemia? I'd like to thank my residents, my partner Bobby Stark, who did the statistics, and my current fellow who's updating the series, Nick Khan, who came to me from Memphis. We studied in over a period of 10 years, 105 anastomoses. Interestingly, the cost did not drop my referral volume. It actually, because we have smart neurologists who understand the limitations, I got referred more cases after costs than even before. I looked at Moyamoya and analyzed intra-op flow data. My bypasses, I had only 1 out of 105 acute occlusions during surgery, but long-term, 10% occluded up to 603 days. When I analyzed the cut flow index that Charbel published, I could not replicate his findings, meaning the CFI did not seem to correlate with the delayed occlusion. I don't know why. I don't know what's different between our two series, but important to note, occlusions tend to be asymptomatic. I looked at the Moyamoya data as well. This is a Kaplan-Meier of the patency rate. Again, same thing, about 10% delayed occlusion, no correlation with the cut flow index, and all of those occlusions remained asymptomatic. I lumped both together, Moyamoya and atherosclerotic, again, could not find a correlation between delayed occlusion and any of the flow measurements I was doing. This is graft survival over time. What matters is clinical outcome, and patients do get better. Whether you look at Moyamoya, this is pre-op MRS, post-op MRS, or cerebral ischemia. This is Moyamoya on the left, atherosclerosis on the right. You look at it, pie chart, same thing. This is an important message. Properly chosen patients improve. We need to keep the bypass skill going. Couple of video examples, how I'm doing it nowadays. 1 donor, 2 recipients, meaning I usually choose the parietal branch of the STA. I'll skip some of this stuff. Physiologically hypoperfused, you can see infarct, pre-op. We like to study the area of uncompensated hypoperfusion, and we're looking at that data currently. Maybe that will allow us to understand which ones might occlude in the future. I like to save the anterior branch to keep going to the skin, and I normally would do a double barrel, not a double barrel, and a side to side and an end to side with the same donor. The 1D, 2R bypass. I'll skip some of that. We're going to skip all that. Just to show the numbers. The numbers are always interesting. This is a 0.8 millimeter vessel. I measure the flow. It was 3 cc per minute antigrade, 10 cc per minute in the other cortical branch before we start the bypass, and we're going to see what happens at the end. You construct. In this case, I sometimes do the side to side first and then end to side, depending on the local anatomy. In this case, I'm doing end to side first. We're going to skip that. Again, interrupted is good for teaching fellows and residents. Now notice the number. I'm measuring the flow. By the way, the way you hold the graft can change the flow. Very important to follow the natural curvature of the donor. And the flow is, I think, 58, here it is, 58 cc per minute before doing the second bypass. So now I'm going to go side to side here, and I'm going to do to the frontal M4. You can do sometimes running, interrupted, depends on the local anatomy of the case. And look at that, 63, it went up. Of course, it makes sense, as I will summarize later. Why does this single donor, double recipient bypass make more sense to increase the flow? Here are the numbers. 63 is meaning cut flow index 1.4 almost, higher than the so-called maximum. I'm going to skip the other case, which is actually, no, let me just show you. It's an identical case, but just to show you the benefit of using ICG that is incorporated in the microscope. It just shows it to you better. And it's identical type of case, just to show you what you can do with that ICG that is infused in your microscope. Again, the cut flow at the end, the total flow is higher than the cut flow at the beginning, and you can play with the saturation of that. These are the numbers. Again, the concept is important, not the numbers. Uncommon bypasses, that's what I'll essentially finish with. Our first speaker showed a very nice example of occipital to pica bypass, very underutilized in posterior cerebral ischemia. This is such a case, multiple posterior circulation ischemia. This is planning before surgery, craniotomy. I also love to use the Colorado needle to get the occipital artery, cutting the dura. Cerebellomedullary fissure, you know, you just expose the pica, the donor. It's not a difficult bypass. It is deeper, but the space is huge. And you just need to make sure you're saving the perforators, and you can bring the pica closer to you as long as you're not avulsing, of course, the anchoring perforators to make the bypass a little easier. And then the rest is the same, just occipital to pica and to side. Again, I'm skipping. It's all repetitive, you know, these anastomoses, as long as you follow the basic principles. I love to use curved needle holders to increase my degree of freedom in maneuvering, and the closure as watertight as I can possibly make it. Not always possible. That's a post-op angiogram. Nice bypass right here. Unusual bypass, occipital artery to angular artery. Again, I thank George Zenonos, who was my fellow, who edited these couple of videos I'm showing. He's now in Pittsburgh. This is a tumor that was unresectable, radiation therapy and radiation-induced hypoperfusion of the left hemisphere. No STA.
Angio suggested absence of flow.
And all I want to show you is that you can use occipital artery to angular artery to achieve an anterior circulation bypass.
Artery was traced.
This is George's lovely voice. And you have to create a tunnel in the bone. And the actual bypass isn't difficult at all. It's just you need to be able to reach with the occipital artery. And it just about makes it to the angular artery. And on the post-op angiogram or in ICG, you can see it here. And you see the tunnel you have to create for the occipital artery. Very similar to what most, I have 2 bonnet bypasses. I don't have 3. I have 2. I'll show you. Well, it's almost identical to Mustafa's case. I can skip it, but what's interesting is the flow measurements. So this is the ipsilateral STA. It only had 7 cc per minute. So it confirmed to me that I cannot use it because the common carotid was occluded. And very similar to what Mustafa showed you, this is a contralateral STA. And of course, you have to put the proximal bypass first. I like to use the bifurcation of the STA to match the saphenous vein ostium. This is kind of going back to Carrel 100 years ago, how you construct an ideal anastomosis. We're going to skip all that. You groove the bone. And the only thing I did slightly different from Mustafa, I added plates on top of the vein, kind of to keep it, titanium plates to keep it in the groove. And at the end, it looked like, you see the plates I put there. I think I'm near. Okay, so to finish, well, almost to finish, technical tips. Keep your bypass donor as short as possible. Try to do a donor to recipient ratio between 1.5 and 2. If you go more than 2, you will have serious problems hemodynamically. Fish mouth the donor unless there is a large discrepancy between donor and recipient. Try to achieve 30 degree, but if it's awkward, 45 degrees is fine. Of course, you think of it geometrically, the smaller the angle, the longer the necessary fish mouth. It becomes totally impractical to do it too much. When you are near the toe and the heel, place your sutures closer together because that's a higher wall shear stress. What are we working on now in progress? We're analyzing the single donor, double recipient bypass flow data. We are doing the analogy with electric circuit. And as you know, it's like circuit in parallel. You drop the R, the more you add. So when you do a double bypass, as I said, the peripheral resistance drops, which is why the flow goes up. We're analyzing angiograms by superimposing them like this, trying to figure out the area of perfusion without compensation. We do it on this. We do it on this as well. Conclusion, please, direct bypass is very effective in reducing stroke in symptomatic Moyamoya disease, certainly also in hemorrhagic Moyamoya as proven by a randomized clinical trial, and very select atherosclerotic occlusive disease, very high immediate patency rate, only 1 out of 105, I failed to get the bypass to go. Intra-op flow measurements, very important. We don't fully understand cut flow index and those concepts. I have no comments on indirect bypass in adults. I've used it extremely rarely. It's almost always possible to do direct bypass. It is a great mistake to abandon bypass surgery for ischemia. You can certainly put your patients in a registry. And lastly, I encourage you to join our University of Miami Thursday series. For example, next Thursday is Juha Hernesniemi and Benju, who will talk about Juha's experience with 40 years of aneurysm surgery. Thank you very much.